playing clarinet in the band, and he was helping the staff, keep the books, and he was a resident of the institution because he had a communication disorder or something like that. It's an amazing story, and this history is just. Okay, sabotage my clip, Gert.
He's waiting for his drink.
Yeah. So, and one of the interesting things, by the way, is the political history of this. In the 1940s, there were two things that led to a big change in the politics of disability. One is the Nazi experience discredited eugenics in a profound way. The other is that people started coming forward. It was mostly middle-class women, and they started telling their stories. And they would tell them, by the way, in places like Ladies' Home Journal, which it's really a shame that these women's magazines have atrophied. Their business model doesn't seem to be working anymore because there was a lot of really serious stuff that people talked about in those venues that they didn't want to talk about in other venues. So pro-buck, who's pro-buck, by the way?
The Good Earth.
The Good Earth.
Yes,
Who said Good Earth?
she was in China.
Yes. And the Good Earth, by the way, has a developmentally disabled character. You get it in Place of Pizza too. So she wrote this in some ways, very courageous thing where she just talked about her experiences. And this book became a monster bestseller. And hundreds of thousands of people read it. They got lots of letters. But she never mentioned her daughter's name. And she also described her daughter as being sort of super profoundly disabled in a way that she had an adopted daughter, Janice Walsh, who wrote an afterword to the book in later years, where it turns out that Carol Buck was a good athlete. She liked to cook. She was a real person whose individuality was never specifically acknowledged. By the way, also Carol Buck said, our family was of the finest genetic stock. And there was nothing, and it turns out that her daughter the actual diagnosis was PKU. What's PKU? It's a genetic form of intellectual disability. What's that?
It was like Peking, like Mongolism.
They've updated the terminology, but it's by the way, one that's now it's readily treatable through diet. I shouldn't say readily treatable, it's treatable through dietary interventions. And it's a really interesting book to read, but it's a painful book to read because it's a product, it's a very courageous thing that's a product of its time and of the experience of this person who had this very painful family experience.
What does PKU stand for?
Somebody want to Google that?
I was thinking that, but then I was thinking you're here.
Why don't you Google it and then read it aloud dramatically?
Oh, right now?
Hey, don't check your 401k.
Crypto. Okay. Crypto. Phenylketonuria?
Yeah. Nicely done. So and there's other book, Dale Evans and Bert Rogers wrote another book that also was a big bestseller. By the way, the profits from these books were used to found the ARC. And so they use their wealth in a very philanthropic way. Any issues in these depictions? Yeah, there's a beautiful little white girl. No diversity. Also,
She doesn't look like she has Down syndrome.
this would not be someone with Down syndrome, but you're right. She doesn't have any morphological symptoms. And she's also really young. All of God's children. By the way, what's great about these women, by the way, is they were awesome community organizers. And I was thinking about that. Remember Sarah Palin? Some of you may be too young to remember Sarah Palin. She was going after Barack Obama because he was a community organizer. And she has a son with Down syndrome. And I was thinking, Governor Palin, women like you were the varsity team for community organizers. It's really striking how much these people accomplished. And there's a wonderful book by James Trent called Inventing the Feeble Mind. If you really want to learn more about this, this was written 31 years ago, and I think it's the best history that I've read. Ari Neiman has a book that's going to come out next year. It's also good. That's phenomenal. This is, but it's really amazing. Actually, it's a phenomenal work. So here are just some of their political organizing strategies. They should be teaching the youngins today. So people are putting ads in the newspaper, trying to mobilize people for collective action. This is this is really serious stuff. And by the way, politicians were very afraid of these women. You do not, if you're at the state capitol, if you're at the Capitol House of Commons, you do not want one of these moms showing up with their cute son saying, you were the reason that my son didn't get what he needed. That is, and they leverage that quite properly. Well, now let me get some actual policy. Anything about the history before I shift gears? Those are gears, by the way. I know it's Ohio, so people already know that, but if this in New York, I'd have to explain that. Anything about the history before I shift gears? I should just quickly shift gears. So let me talk about how some of the politics and economics and social stigma play out as we think about the different ways that we've tried to move people with various disabilities out of institutional settings. We give a sense of the word deinstitutionalization and the valence that word has. It's kind of taken on a negative connotation because it's kind of come to mean there's a bunch of liberal people who took people with serious mental illness out of institutions, moved them out in the community, and they ended up homeless in Times Square, screaming at people and pushing people in the subway. If you look at a lot of op-eds that have the word deinstitutionalization in it, it's got some valence like that. And I'll say there's a lot wrong with that framing. But what's interesting is that intellectual disability is not the way it happened. There was deinstitutionalization, very different trajectory.
So, can I ask a little quick question?
Yes.
Just, no, I mean, not to bring up President Trump in this context, but he started using this language of insane asylums, and there's one other word, and it wasn't clear. It wasn't clear he knew what he was really evoking. But did you have a reaction to that sort of moment where he started within this context?
Yeah, I think he was speaking. He was speaking in the lexicon of 1980s New York in a lot of ways. And there actually were a lot of challenges. There was a lot that was done wrong in some of our policies towards people with serious mental illness that he was reacting to. But yeah, there's a Jewish expression, an Altekocker, which is like an old head. There are times when President Trump calls that metaphor to mind when I listen to him talk. Although most of the Altekockers that I know I like better. So, but let me just describe what the theory was and what was good and bad about the theory. And the basic theory was moving people from high-cost, inhumane public institutions to more efficiently community-based care would help people live better as humans and would save us a ton of money. President Kennedy was one of the early originators of this. And what's interesting is the human argument was right in a lot of ways. And the thing that's sad about the SMI example, serious mental illness example, is there's the guy who got out of the institution, who pushed the person on the subway. That's on the front page of the paper. There's the 38 guys who got out of the institution. They're living in an apartment on SSI, and they're living a better life, but they're totally out of sight, out of mind, because they're not doing anything that's bringing them into the paper. And so the availability heuristic really distorts conversation. What's the availability heuristic? Anybody here behavioral economists? People think when something is very vivid comes to mind that it's more common than it is. That's the availability heuristic. And what's striking is, so let me describe the economic argument and the human argument. And pardon me, I'm obviously babbling like crazy, so you guys are being very tolerant, and I appreciate it. So the economic argument, we have this institution. It costs us $10 million a year, We got 100 guys in it. That's $100,000 per guy. There's this guy who's sitting in the back who's like playing cards with the staff. He's bored. Like, why are we spending $100,000 on that guy? He should be out in the community where we can give him, where he can live a better life and we're not spending $100,000 on him. There's two pieces of what I just said. There's the human piece and the economic piece. The human piece is correct. Why is the economic piece not correct? He is the cheapest patient in that entire hospital. They're spending zero staff time on him. His needs are very basic. It's going to actually be more expensive. What it costs them is he's got a cot. They're feeding him, which is still going to have to do in a community setting. And he's really not requiring a lot of staff support. So moving him out into the community is the right thing to do because he's a human who deserves that. But don't think we're going to save money from that. And when we make economic arguments as the way that we think is the best way to justify humane policies, we sometimes run into trouble when those arguments aren't right. It's like the argument, a lot of people were saying we should have universal coverage because it will reduce emergency department use, which it doesn't do. And we should have universal coverage because when people are sick, they have a right to get taken care of. And it's a good thing if people go into the emergency room when they're sick. But there are a lot of, what was interesting, and by the way, Christopher Jenks has a wonderful book called The Homeless, which has now been out a long time. Which really played this out. And when I read Jenks, I really was thinking, why is it that the IDD world, deinstitutionalization was pretty successful when it was really not particularly successful for people with serious mental illness? Right, here's images of IDD in popular culture. This is not. Anybody remember these TV shows? President Trump probably remembers some of these TV shows better than you do. Like LA Law, he probably watched some episodes. These are people with autism, with Down syndrome. Pretty nice images, right? Not very scary. And when we think about people with serious mental illness, we're up against a lot, by the way. This is from a week ago.
Yeah.
This is a man with serious mental illness who murdered that woman. And that's Hannibal Lecter, from The Silence of the Lambs. When people think about who lives with serious mental illness in America, these kinds of images are very powerful. And by the way, and it's not made up. There are people with serious mental illness who raise public safety issues. That is a reality. Boy, they're a small minority of people with serious mental illness. So here, by the way, is one of the ways that stigma gets expressed in policy. This is a wonderful paper by Wong and Stanhope. This is a map of, anybody recognize the city here? It's Philadelphia. So they mapped on this side, they took all the residential settings for people with intellectual disability, and the size of the dot is how many people live in it. And they did the same thing for people with behavioral health challenges. And what they found was, first of all, there's a lot of big dots on this side. A lot of people live in large congregate areas. But also, if you look at this map, if you try to run a regression, how many people here are like super regression gurus and geospatial stuff? Okay, there were how many of you are regression gurus? No one?
They're being modest.
You could not run a regression that would predict the characteristics of any of these neighborhoods by how many of these dots are here. It's a uniform distribution across Philadelphia. If I asked my friends, is there a group home for people with intellectual disabilities in their neighborhood, most people would say, yeah, I don't know. Kind of interesting question, I never thought about it. If you ask people, is there a group home for people who are in recovery from heroin addiction in your neighborhood? That people know. And so it's just dramatic how easier it is to do a good deinstitutionalization strategy when you have community support. So there's social acceptance, political mobilization, and also you have to actually provide high-quality services. One of the things that's really striking, suppose you saved a lot of money if you took that guy, remember my example with the guy who was playing cards in the mental institution? Suppose you took that guy out of that institution and you genuinely saved a lot of money. There has to be some process of immaculate conception whereby the money that you saved is somehow miraculously channeled to the funding stream for the community-based services, which is provided by totally different organization, etc. That happens when you have a political constituency that makes it happen. There's a bunch of people who come to the State House and they say, these are these guys, they're getting out of the institution. This is my son. He needs to have these supports. You need that. And it was dramatic how the IDP community was politically successful in making that happen. In a way that but I should say it also was a big unfunded mandate on family caregivers. And that's, a lot of the costs of the institutionalization were borne by families. And that is something that needs to be acknowledged. Now, one of the things that's really, now let me get to family caregiving. Any questions before I move on? Any cleanup that's needed? They're wondering what's wrong with this guy? We're all being so tolerant. So one thing is, so people are they're not living in an institution, they're living with mom a lot of the time. And one of the challenges you have with that is that people with IDD basically live a long time. Pretty much, not, I wouldn't say quite normal lifespan. People with Down syndrome have life expectancy of 60. But people live a long time. And so they're going to outlive a lot of their primary caregivers. There's 1 million people with IDD who live with caregivers over the age of 60. And if you ask caregivers, what's your plan? Most people don't have a plan. Or they have an implicit plan that they never really discussed with all the other people that have to be engaged for that plan to work. But also, people are on very long waiting lists for Medicaid, home and community-based services. Usually the waiting list is about 5 years. By Texas, they rocked this one. They have, this is now, I think this data are now 2 years old, but they actually had 58% of all the people in the United States on the wait list in Texas. Illinois, we, by the way, considering how much smaller our population is than many of the states that are ahead of us, we did pretty well too. So there's lots of people waiting a long time on waiting lists for services. In particular, as people age, that is a real problem. But some states have no waiting list. Yes?
So, I mean, what's going on in Texas? I'm just curious.
They don't want to spend money on Medicaid. I mean, if you want to save money on Medicaid, you know, there's all these, if you look at the political iconography of Medicaid, they show this young guy who's like sleeping on the couch in his mom's basement, and he's on Medicaid, and why is this guy on it? And why are we paying for this guy's health care? And when you think about that, for 38 seconds, you're like, wait a minute, he is the cheapest recipient in the history of Medicaid. The dude hasn't been to the doctor in 5 years. He should go. If you want to save money on Medicaid, people with IDD are expensive and they live a long time. So the fiscal pressures are really quite profound. If you know any of those guys, send them to me, by the way. The guys, you know, I'll talk to his mom. So let me talk a little bit more about families and how families make decisions. I'm sorry, I have so much material here. I'm obviously going to filibuster out the time. So Rebecca Feinstein and I went to an academic medical center. We just talked to people about their plans. And by the most common thing we heard was, our plan is to someday have a plan. How many of you, by the way, that you could be saying that about anybody else? So we did some focus groups and we did some phone interviews, pretty small sample. This is where these qualitative work, I'm not generally a qualitative researcher, but this was essential to do qualitative work for this. By the way, the saddest thing was my plans to live one day longer than my child. We heard that from a bunch of people. And I should say, by the way, Fragile X is a particular thing. If we talk to people with other diagnoses, we would have had something different. The other thing is that our sample was really white and pretty much upper SES. I was going on face groups, recruiting people, things like that. That's who was jazzed to participate in these studies. And we did not interview people living with Fragile X themselves, although some of our caregivers had the Fragile X. If you know anything about the genetics of Fragile X, the moms had a Fragile X, some form of Fragile X going on. One of the most striking things that we found was a really high prevalence of safety issues. Turns out about a third of parents, this is not from our study, this is from another study, about a third of parents who care for people with Fragile X are injured by usually their son. And when that happens, that's a regular occurrence. And I said one of the things I do in Chicago is I train police officers to work with people with IDD. And I was talking to these women and they had bruises. And I would say stuff like why is he, and you know, he's not aggressive or violent. I know what triggers it. I spend the vast majority of my days working around learning how to prevent something like that from happening. This is a woman who had a cracked rib because he pushed her down the stairs. That's 326. This is a person who had another serious injury. The other thing was that a lot of the people said, you know, it's not fun living with this stuff with my son, but any place that I want to send him that will take him, the places I really want to send him, they're not going to take him because he's got these behaviors. The places that will take him, they got other young guys with the same behaviors. And like he's going to get hurt or somebody else is going to get hurt because he's going to get into a fight with another 25-year-old guy. So I keep him at home. It's not great, but that's the way I'm dealing with this right now. I should say we have not experienced that in our home. But one thing that we did when I was talking to my wife about, there's a lot of issues in the national news where someone's IDD is injured or killed by a police officer periodically. And one thing that my wife said is never call 911. My brother-in-law is 260 pounds. He's 2 Harold, but he's pretty tough. He actually hit me one time because I yelled at my 9-year-old daughter, who he loves. And he got so upset that he like smacked me. And I was driving at the time. And we pulled over and we agreed I was not going to do that. I was not going to yell at my daughter. He was not going to use his hands. But you know, this is what families have to deal with. Pardon me, as I said, I'll pay the receptionist on the way out. The other theme is that there's so much of the services are provided for young people, particularly if you go to a good public school. You know, if you're, and there's lots of reasons why that's happening, but there's a lot of attention, quite rightly paid to what's called the disability cliff. People age out of school-based services. Like what happens when your son ages out of the K through 12 world. And there's a lot of other life transitions that get a lot less attention, particularly when they're transitions in the caregiver's life. I'm retired now, or whatever. So you know, here's just some articles on the disability cliff. And the choice architecture that we give to families makes it really hard. What do I mean by choice architecture? Anybody here familiar with that term? Anybody nudged by?
The way choices are structured and set up before, like from the beginning?
Yeah, so how are we presenting the choice to people? There, Richard Thaler and Kat Sunstein has a book called Nudge where they use this. You know, it's really, you know, if you're a caregiver, you have these relentless everyday demands of being a caregiver, and there's also all these long-term issues which you know you're supposed to be working on, and someday, I'm going to get to that. And unfortunately, sometimes that someday is, you get to that when the crisis hits. And so there's a lot about the way that we structure things and the way families operate that really makes long-term planning hard. By the way, this is also where the administrative burden work, like burden Moynihan, is so critical because public systems are so difficult to navigate for so many people. And one thing is complexity creates disparity. So if you're an upper middle class family with a son with Down syndrome, you can hire people with expertise who can help you do this. Also, if your son goes to a really high-quality school, let's suppose that your son goes to New Trier High School in northern suburbs of Chicago versus going to a high school in Bronzeville in Chicago. The social workers that are in Winnetka, in the New Trier High School, they're spending most of their time on kids with disabilities. A lot of their time. There's many fewer kids who are homeless. There's many fewer kids who are getting arrested. We're having a lot of the issues that are really common among low-income people. And plus, the school has more resources, more dollars per student. So the staff can really help the families. They can say, let's really spend some time talking about what the plan is for your son. And that's really hard to do if you're a social worker in an under-resourced, low-income community that has 55 billion other problems. And also, of course, if you have family wealth, then the stakes are a little lower for some of the things that happen. So it's taken us a little while before we can get our son into this housing arrangement, but we have some ways that we can navigate that. So the complexity of these processes just creates enormous disparities. One of the stupidest things, we were talking about this at lunch, if you had to make a contest for the stupidest thing in all of American social policy, which I knew would be a big field, the $2,000 asset limit for SSI would definitely be competitive. Last raised 1989. If it were actually at the level that it was in 1972, it would be more than $13,000. So families are trying to save. By the way, I don't know why the Affordable Care Act left this unaddressed. That was a complete F up in the Affordable Care Act that we didn't do that. Could have been one paragraph. So families try to navigate around. I have a son who's going to be on SSI when he's an adult. I got to figure out how to navigate, how to put some resources aside for my son, but I don't want to endanger his public benefits. Okay? So it's hard to do. Ideally what you'd like to do is just have like a saving account for your son or a Vanguard fund or something like that for your son. You can't do that straight up because you'd be threatening his public benefits. So you try to do. There's all kinds of workarounds that people do. This is where the stupid and crazy of everyday life comes in. So like I'm a 78-year-old mom, and I've got two kids, Susan and Sam. And Sam lives in an IUD, and I say to Susan, I'm going to leave you my house because if I leave Sam half the house, that's going to screw up his SSI. But just half of this is really his. But I just can't have a paper trail. And so then Susan, because she's head tripping about various other stuff, she's getting divorced. And now they're fighting about the value of this house. And half of it is really Sam's, but there's nothing written about that. Or she decides she's going to try to run Sam's life because she's got the leverage on him, because she's got the resources. So there's just lots of, it turns out there's lots of workarounds that exist to do this. Does anybody here, some of you raised your hands, anybody here use some of those workarounds for your own loved ones? Things like,
Aware of a situation where the individual owns a car. They can't drive, but because the assets wouldn't count against the limit.
oh, that's a good strategy. So you can do things like set up special needs trusts. There's various things you can do. And when I talk to people, when I go on Facebook groups and so on, I ask people about it. I get really awesome strategies that people are proposing. And all the people proposing those strategies are these guys like, I have an MBA from the University of Chicago, and so I figured out how to do that. Now, 2014, Congress created these things called ABLE accounts, and we're trying to deal with this issue. It's like a 529 account. You can put up to $19,000 a year into the account. You can pretty much spend it on anything that promotes the well-being or the independence of the person. They're called qualifying disability expenses, which is actually unfortunate because people are confused by that. If they just said you can spend this on anything that promotes independence and well-being, a lot of families would be less scared to do it. So So our research group has been trying to understand who has able accounts and how can we get the word out to more people. As they have the first 100,000 doesn't affect your benefits at all. That will cut off your cash benefits if it goes over 100. We use to your Medicaid, which for a lot of people is more important. So I will skip over a lot of the junk DNA around able accounts. But when we looked at who had them, what we found was all the money was held by young adults with IDD living in high-income communities. That's where all the money was. And that's where all the people were who kind of knew that able accounts existed. And they were told that by financial professionals that they worked with. Now, one thing that is really what I wish that we would do is Medicaid would just open the able account for you and put in like $50 a month, which would be nothing in terms of what Medicaid's spending on those guys, but would actually give people independence. I think that's, I should say, we're doing a randomized control trial. We spent 18 months meeting weekly with the Social Security Administration. We were about to send letters to 97,000 families, help them with able accounts. And then we got a letter from, after the election, that this no longer matches the current priorities of the Social Security Administration. It was canceled, which is really unfair.
What are those priorities?
That's for my next lecture. Let me talk a little bit about psychiatric comorbidity, just show you some of the work that we've done. Because we like to think of people with IDD as being cute and cuddly and stuff, and because we're thinking about children and young adults, the high prevalence of various kinds of psychiatric stuff is sometimes overlooked in the public conversation. And there's also something called diagnostic shadowing, which is when someone has psychiatric symptoms, it's misinterpreted by the care team as a symptom of their intellectual disability when it's something else. And so, by the way, the fact that we were going to NIH thing about where we get this funded, and this is for adults who are like age 50, and they said, oh, you have to go to the National Institute of Child Health and Human Development for that to be funded, which is so metaphorical for how we think of people with IDD as being kids. So we looked at 30 million patient encounters from calendar year 2019 across the United States in something called the National Emergency Department Samples. Everybody use this data set? It's a really interesting data set. It's part of the HCUP data. And so we looked at what the kinds of things that were showing up in patient encounters. I should say this is not person level data, this is encounter level data. And I'm happy to send the paper, it just came out in the Psychiatric Service. I put this up just to look cool. This is just our sample selection flow chart. So we ended up with, we found about 39,000 people with cerebral palsy, 34,000 with autism, 70,000 with intellectual disabilities. These are overlapping categories, but we had a lot of data for individual encounters. And by the way, the people with IDD were a younger group than the entire group of people showing up in the emergency department, more male group, and a white group. And here's what we found. Here's a couple things that we found. So one is that really high rates with the autism folks, we found really high rates of various kinds of mental health disorders. And also for intellectual disability that was not Down syndrome. That's good. And for the Down syndrome group, what we found was pretty low indications for mental health things, but high rates of dementia. I'm going to close with that. By the way, also suicidality was, particularly the autism group, it's a real human experience of living with autism. See how that can happen. But here's what we found with dementia. The green bar is Down syndrome, and it's the proportion of ED visits that had an indication for dementia. And in the 45 to 49 group, we found a higher prevalence of indicated dementia than we did in the general population over age 70. And people people with Down syndrome have a 90% dementia lifetime risk. And this is a population that lives to age 60. So you can see it's over a third of all the ED visits when you get over age 55. And so, and one of the things that's really challenging about dementia is, people with Down syndrome don't have a lot of externalizing behaviors. But when they start to develop dementia, sometimes those behaviors emerge. So a lot of the time, that's coming up because someone's suddenly doing some behaviors that are really, we're unaccustomed to seeing that from that guy. And so you have an 82-year-old mom whose 45-year-old son is starting to develop dementia, and all of a sudden he's pushing her and stuff. And that's a real challenge. So, so I'm going to close things out. I sometimes use this as my study limitation slide. That's us pretending that we didn't go to the snack bar at the minor league baseball game. So, this problem is really overlooked because we're thinking about people with IND as children. And this is the reality that families are experiencing. And we have to figure out ways to help people age in place when they're living with IDD. So our psychiatric services paper, we have an accompanying commentary in Nomad Quarterly. We talk about some of the things that we need to do in there. So we just, I won't say too much, this is kind of self-explanatory. We really have to raise the game of the healthcare system to take care of older adults who live with IDD. And also thinking about when do we want people to be going into nursing homes? Because one thing about the deinstitutionalization debate is that there's a sense no one should be in a nursing home. Well, there are people whose care needs, they should be in a nursing home. And so one of the things we have to do is to build up a care system that can deal with this issue. And there's some really interesting stuff on the IDEAL project, where they give some really good recommendations for how to design a care system to do that. The irony in our paper is the emergency care system seems to be the portal by which we see some of these social problems that we're not dealing with properly any other way. So, okay. I anticipated that I was going to go on. I'm going to stop here. But happy to answer any questions or to... Yes?
So what about the issues surrounding like power of attorney questions or like questions over medical care? So like, let's say someone with an intellectual disability is in like some sort of group home. Is it like the group home that is responsible for making decisions about medical care, or is that left up to like a guardian still? Like, if they have a parent who's still involved in their life, like that just seems like a big gray area, especially if someone is aging and is unable to make those decisions.
It is a very gray area. Usually the group home has to have some kind of guardianship capacity just because there's so many things that are happening in the group home. They just have to be able to deal with it. And there's a nurse on staff or whatever who's administering medicine and stuff. But that's a very murky area, and particularly when the family disagrees with something that's happening in the group home. So yes.
On NPR this morning, as I was driving in, they were talking about the paperwork world of importers right now because of all the shifting tariffs and it's so complicated. How can they make business decisions? So there was a consulting company that developed an AI tool where they could very quickly, I want to import the furniture from these 3 places. What will it cost me? And they get a very quick answer. All the paperwork burden that you were talking about seems like a great opportunity for AI. Maybe a PhD.
That's a really interesting suggestion. I think it would have to be co-designed with people, with service providers and families.
Yeah.
One of the challenges is there's such a heterogeneity of circumstance. But you're right, there could be some real potential, and especially when you take things that are really some very prevalent problems. It seems like that could be a great idea.
So you can, then you could put in, what if we move to a different state? What if a divorce happens? What if, all those kinds of things, so that you can make informed decisions. But, you don't have the time to sort it all out because you have the day-to-day pressure. But an AI tool can do it more quickly.
I wish there were an AI tool when we were starting this. I'm not sure I would have moved to Illinois if I had access to more information. It is a real challenge. It's,
Yeah, so I have a question about political advocacy for these groups. Like, is it fragmented? Is there a lot of lobbying groups, or is it consolidated? What does that landscape look like to advance these policy issues?
good question. Adults, the Down syndrome community, which was really the political engine behind the ABLE accounts, is an effective political constituency. And they do, and because there's such public support for people with IDD, there's no sort of standard oppositional interest groups in the way there might be for some other issues. One of the challenges is that a lot of the things that they want are very expensive. So very often they're in coalition with other groups, like say opposing the Medicaid cuts, things like that. And I also think that the landscape is very middle class for advocates for people with IDD. And it is families like ours who are organized, who have the resources, and who are a feared constituency. And like if you say who is looking at the city of Chicago to look at the quality of group homes in the south side of Chicago, who's a politically feared constituency, I think if you ask any politician that, they wouldn't know the answer. If you said, what about in these suburbs? They'd say, oh yeah, those people. You do not want to cross those people. So I think there's another hand up. Or is it word? Yes.
From a policy perspective, is there a particular country or countries that we should look to?
That's a good question. I think a bunch of the Western European countries are doing things well, although I think that it's a segmented question. I think that there's universal health systems that do a much better job on long-term services and supports. I think that some of them are more frank in their. They don't have the Americans with Disabilities Act or the Olmstead. Well, I mentioned the Olmstead decision on a slide. What was the Olmstead decision? Anybody here? The most important Supreme Court decision you've never heard of. Yeah.
Doesn't that have to do with like discrimination against people with disabilities by government services?
It said that people have a right to be in the least restrictive environment that meets their needs. The 1999 Olmstead decision, and a lot of the litigation around nursing homes is based on Olmstead. It's Ruth Bader Ginsburg, one of her singular accomplishments. I'm over, so I think I'm going to stop here. But if people want to talk to me, I'm available. Thanks for.